is close to the skin. So, of course, that's that right there. It's pretty, probably quarter of the brain size. It's pretty sizable. Here it is coming through the skin at this point. So here go from this. Okay, so we took the whole mandible out, the whole, the whole cheek lining. Outside the skin's gone. This is the remaining tongue. Here's your great vessels ready for anastomoses. Okay, and we obviously do a trach because that's not going to be good for airway. So in this case, we did a scapula flap. So we borrow a little bit of bone and a little bit of skin, and we harvest the blood supply that feeds all that. Then so here's an example of what that looks like. Here's a vessel, here's your skin, here's your bone right there. Bring it up. And then we also use a custom implant mandible recount. We don't always do this, but in this case we did. This custom fits, so it's going to fit like a glove. So here it is. Here's the plate, and here's the bone. And we're kind of sewing the inside of the mouth. We're going to de-epithelialize. This area can be buried, and then this part will be outside the face. So here, that's what it looks like. Okay. So it's a free flap. So this the vessel has to work. Okay. So very important to check the flap Dopplers, check the flap skin color. Again, if it's already purple, that's already laid. But check those two things. And then trach, want to make sure it's sewn in properly. And no trach ties for first 8 days. After 8 days, we take the sutures out and we put a loose trach tie at that point. Nothing circumferential around the neck. And be mindful of the Doppler. You can see these wires just sticking out. We usually put Tegaderm to cover this, but sometimes we had those pulled out. And this, obviously interfered with the monitoring. Check the drains for any saliva leaking. Activity-wise, you can use a shoulder's tolerance. There's no weight restrictions. This can be just pain, be the limiting factor here. And you can compress it all, the axilla all you want, because that's not what the blood supply is. Fibula flap. So you're going to see a lot of these. A lot of the jaw reconstruction is primarily done with this. The scapula, we use it more for upper face reconstruction. So here's a typical lower, mandible swain. Here's the jaw. Here's the tongue. Mandible, tongue. So big hole. This typical fibula. We didn't harvest skin in this patient, but this is not the same patient, obviously. But anyway, we borrow a fibula. Now, the interesting about fibula is that it's not a weight-bearing bone. It's just like extra body part that whoever made us put it in there. Tibia is weight-bearing, so they can actually walk on this immediately. Right? So here is, we de-epithelialize the skin here. This part's going to get buried as the skin gets draped over. This part will stay inside the mouth. So here is what it looks like. And we just basically peel the face back over. So it looks worse than it really is until we're all done. So anyway, same thing as other flap. We want to make sure, check the Dopplers, skin flap, trach sewn in, nothing circumferential around the neck, Doppler wires, drains. And then fibula can walk on it. The only thing is that if the skin graft gets placed where the donor skin came from, there's a wound vac on that. So it doesn't really shear too much, but we don't want them walking too much on that for the first 7 days while the skin graft is taken. After that, it's not really a big deal. So here it is. All right, radioform free flap. So radioform used a lot for smaller defects. There's a patient with a tongue defect involving the mandible and the buccal cheek. Here's a little bit of bone you can see, and the buccal, the cheek lining on that side of the tongue. In this case, we did a radioform. And actually, this doesn't cause any motor problems. Okay, I know it looks pretty crazy, but.
Do you guys do that too, or is that along with vascular or ortho, or is it just shelf straight? So you're full body, not just head and neck.
Yeah. Yeah.
Wow.
Yeah. So here's the tongue gets sewn in. So me and Dr. Kendall does this kind of stuff. So here's the tongue, and then one interesting thing is they always look terrible when they come in.
Yeah, look how good she looks.
And this is what she looks like, okay? This is probably about 6 months out. You can see how much this tissue shrank down to that.
Whoa.
Okay.
Wow, she looks really good.
So, yeah, I mean...
You do a good job.
Thank you. They heal well. That's the big thing. So, a lot of times this tissue is really swollen, They also get radiated afterwards. Almost 100% of these cancer recurrence patients get radiated again. So radiation melts a lot of the fat and all this stuff. So we always put more than we need. We usually wait about 6 months to make them look prettier and remove extra tissue. So they look, our goal is to make them look pretty normal so they don't look like there's some crazy surgery though.
So you would go back if you felt like in 6 months she didn't look good
Yeah.
like that.
Yeah, in
Okay.
about 6 months, once you're cancer free, for at least 6 months, that's when we would start doing these reconstructions to make them look, prettier. So radiaform, same deal, check the flap, Dopplers and all that stuff. Now, in terms of activity, LUMVAC gets placed over on this area, so you have a skin graft here, similar to kind of the fibula. That stays on for about 7 days, but no issue with moving their hands. Okay, just again down to pain control issue. So anterior lateral thigh flap. Another patient, this patient also had a recurrence. Here's you can see they split this jaw to get in here before. There's a big soft tissue you can see kind of growing here. So you can see the skin's different on this side and the other side. So here is before the surgery. You can see there's a weird bulk.
Yeah.
It's hard to figure out what the heck it was, but we had removed. This is larynx and things like that. So here's kind of what it looked like. We had split the guy's jaw here. This is uvula, so like kind of at the back of the nose, and from the nose all the way down to the esophagus been removed. This is your spine that we're looking at. So we actually removed some of the prevertebral fascia here. So this is bare spine. Okay. And you can see this is carotid artery. There's no jug and everything removed on that side. Here's carotid on the other side. This is the internal jugular vein, so we have to go to that side, okay? Because there's no vein on the other side. And also, there's no larynx. You guys, there's no voice box there. So this is trachea. The whole larynx and the esophagus been taken out, okay? So in this case, we use the anterior lateral thigh flap. Sometimes we use rectus flap, which is stomach muscle. This is what we use for big skin coverage. So here it is. So for orientation, this is trach, and this is the esophageal mucosal lining. Okay, so there's a trach mucosal lining, and we're gonna fold this skin into like a cylinder, essentially. Okay, I'm gonna keep folding it up. You see it's getting folded up. Here's like showing suction going in there like a cylinder. Zip all the way up to the tongue. We put the plate back on, close the mandible off. Obviously, there's a big skin defect from the cancer being removed, so we did what we call a cervical deltoid pectoral flap, where we harvest all this skin here and rotate it in, and here it is.
Wow, he looks good.
Thank you. It took a long time, but yeah.
I would have never thought.
So this particular patient, very important to not vomit, as you could see, like the whole pharyngeal lining, vomit that's going to just explode. And then activity-wise, you can start walking on this same day. We can usually close this wound primarily. So there's a scar there, but no interference with walking. Okay.
For the nausea and vomiting, do these patients have like just scheduled
Usually
meds,
like
or are you
Zofran.
right? But I mean, you just give them regardless of whether they're nauseous. Like,
Well, just if they're nauseated.
Okay.
And usually what we see is we're a little bit aggressive with nutrition. So sometimes if their bowel's not really caught up and we push them, that's when they vomit. So I tell the residents to just trickle feed until like they start having bowel movement. And then if they don't have bowel movement, just really crank up the enema. And then once their bowel's moving, then crank up the 2 feeds. Because we had, we would just force feed these guys and just vomit. So usually not really a huge issue, especially once they're on this floor. A lot of these issues have been kind of worked out.
okay.
But Zofran, scopolamine patches. And if they say like nauseated, just give them something so that they don't progress onto vomiting. Or just hold the 2 feet.
Walking on post-op day 0.
After
Yep.
I had all that done.
Wow.
Well, she was probably sleeping.
Yeah,
but,
well.
Technically you
But
can
you
walk.
can.
It's just skin and muscle hair.
Yeah.
So.
Well, it's more this.
Yeah, you gotta worry about it. It's like the head
Skin and
That's still attached. So now, laryngectomy patient. This guy, we had taken out the larynx, okay? Very important. I don't know if Dr. Rutter touched on this yesterday.
A little bit.
A little bit. So normally, like all of us, you know, we breathe through the nose and the mouth. So we breathe this way, and then we talk. You know, the wind gets through the trachea, air gets pushed up, and we talk. Okay. Laryngectomy patient, we had removed the larynx. Okay. So what we do is take this out, and we bring the trachea towards the skin like this. Okay. And then this lining is sewn to whatever's left up there. Okay. So. And the laryngectomy patients, they don't typically need a trach because we actually bring the trachea, the cartilage up to the skin, so there's just like a hole there. Have you guys probably seen that,
Yeah.
right? Now we do sometimes put trach if we're worried about it like constricting down. So sometimes like a Larry tube or things like that just to stent it open, but you don't really need a trach. Okay. Now with these people, when they have problem breathing, unfortunately, people just automatically start backmasking their mouth just because that's what we do, right? So we actually, you know, not here, thankfully, but in other institutions, like we have people die as a result of that, like in residency. I've seen that because even the anesthesiologists, they're like, let's start backmasking this person. You just like insufflate their esophagus, okay, and it's going to vomit. The good news, they cannot aspirate. Physically impossible to aspirate. So, you know, you can't get toothies coming out of the trach because it's completely detached. Okay. So if you have any airway issues, these people, sorry, this keeps going. You want to make sure you try to, you know, bag mask here. Okay. Ideally, you have a trach in the room or like an ET tube, so you can just dunk it in, and then you can use that to bag mask. It's much safer. Okay. Generally, any of our patient with trach, and if it's open, that's the route we want to go for. Okay. Did anyone give you guys talk on airway stuff yet?
Dr. Moore, right? Or didn't?
She didn't really. I mean, she did a little bit, but
Yeah.
most of her stuff was like
Who
more
do you-
outpatient
Who
kind
do you
of.
think
Yeah.
we should reach out to for it?
Yeah, who would?
I guess all of us.
Okay.
All the ENTs should know how to do airway stuff.
Okay.
Because we're the backup for anesthesia.
Okay.
So the main thing is this, like, you know, there's a whole other topic, but airway is super simple. Is think of it like a plumbing issue. Okay, you have air going down, so it should go from your mouth to the chest, right, through the trachea, and you got to figure out where it's obstructed. Okay, if it's obstructing the mouth, don't try to go through the mouth. Try to go to the neck. That's sort of the reasoning for trach. Okay. If it's obstruction up here, then put an oral, like, you know, like let's say like a really fat guy with a really huge palate issue blocking up here at the nose. They usually snore at that point, what we call stertor. Then you could put an oral airway in, so meaning you're bypassing the nose part of it. Okay. If a patient has really big tongue, you can bypass it by using a nasal trumpet. You guys know the green trumpet? So you're going through the nose and going behind the tongue and end up right over the voice box. So you try to, once you know where the obstruction is, you try to bypass it. So you can do the nasal trumpet to go from nose to the behind the tongue, or airway if the nose is blocked. If the whole thing's blocked, then you go to the neck, which is a trach. Okay. That's really it. And then the two thing about trach is there's a regular Shally trachs, usually use a size 6. They're either cuffed, has a balloon on it if they need a ventilation, cuffless, meaning they don't have any cuff on it, you can't ventilate with them. Now the important thing is, hope you guys have do you guys have proximal XLT trachs?
T-trachs, does it sound familiar?
No, so you guys should probably have it.
Okay.
So what that is so there's a proximal XLT and there's a distal XLT.
Okay.
Okay. These are not to be rude, but it's for fat people. Okay. The proximal part of this.
Oh, I think we've seen this before.
Okay.
I think
With the extra long.
Yeah.
Yeah.
They're extra long. Yeah. So
Okay.
if they
We don't keep them up here though.
Yeah,
Right.
probably should. Yeah. And they're hard to find, but OR has it, Central has it.
Okay.
So the proximal talks about going from the skin to the trachea. So if you're like 400-pound guy, you need the depth to reach the trachea. Otherwise, it doesn't reach. Okay. So the proximal XLT is helpful for that. So usually like 60, 70, or 80, or like 6, 7, 8. Okay. Proximal XLTs. The distal XLTs are once you're in the trachea going to the bronchi. So those are more people with like tracheomalacia, or like a lung cancer that's obstructing. So probably not going to need those as much as you would for proximal implant. So proximal you probably should have up here just in case. Okay. So if the trach comes out, obviously call ENT resident. They should just run up here. And then the things that we do is very helpful for us is have a suction ready, because just you got to suction the blood and whatever coming out of there. And then if you have like an ET tube, you can usually dunk those easier than getting a trach in there, just because it's a little bit more flexible. And the idea is, if you had a 6 that doesn't fit anymore, you want to go a size smaller. So like it could be like the smallest little baby trach or a baby ET tube, and those are ideally what we want to use just to get an airway in. Okay. So like an ET tube would be very helpful. And then we usually do like a 4, 6, 7, 8 Shiley trachs, and also for bigger people like a proximal XLT trachs. And then the other thing what we do is, if there's a concern like, is it really in the airway or not? Because what could happen is these trachs, instead of it like kind of, if a regular person with a trach is going to sit like this, or it could sit in the airway, which is what we want, okay? But sometimes it could sit in front. It's what we call false trach. Okay, so it looks like it's in there, but it's not in the trachea, okay? And then you get a situation where like you don't really get a good CO2 return. You try to pass suction in, it doesn't go anywhere. That means it's not in the trachea. It's just hitting like a blind pouch, okay? So what we do is the residents usually show up with a flexible scope, like the ones that we can look at the scope. They can actually look in there and look for the trachea, and then you can guide the trachea guide it over the scope into the trachea. Does that make sense?
Mm-hmm.
Kind of like salvaging technique.
Yeah.
So once you find the trachea, just slide that in. That's pretty much you got to know for a trachea. Okay. So in summary, so free flaps. So again, these patients have really bad problems. So these patients seeing me, they have a really bad situation. So thankfully, a lot of them we get through thanks to you guys. Free flap failure is really not a good option. Every single one of these have to work. And in terms of all of our patients, just be mindful of the airways. You got to be familiarized with yourself with the trach, and we'd be happy to give you guys more like formal in-service if you guys need. But that's essentially what I just told you is what you need to know. And then Dopplers, very important for early flap problems. Again, this is more in the ICU situation. Once they're here on the step down or on the floor, we do like Q4, and then day 10 we just pull the Dopplers out. We don't really care at that point. If there's any problems, try to troubleshoot. Try a different box. See if the power's plugged in. Check the battery. If there's a problem, call the ENT resident. And once the blood clot forms, you have about 5 hours to save the flap. It's an emergency situation at that point. Purple skin flap changes a very bad size, so kind of late. Typically not salvageable at that point. And we generally order 10,000 units of IV heparin on the way to the OR. And to avoid flap from clotting, we do try to avoid hypotension. One thing I forgot to mention, we generally keep these people on aspirin and heparin sub-Q. Okay. And if they clot actively during surgery, we'll actually put them on heparin drip, and that's more in the ICU situation. And just be aware of where the blood vessels are, so you don't compress it. No PICC line the same side as the vessel anastomoses or wherever the flap came from. Trach, we'll do trach essentially for anybody. If you're thinking that you're going to have an airway issue, you're going to trach them essentially, or at least intubate them. Laryngectomy patient, remember to bag mask the stoma, not the mouth. And wound infection is a huge problem. Thankfully not often, but still is a big problem. Do IV antibiotics, check the drains for salivary leaks, change gloves often, dealing with drains, and high protein, high calorie diet, and thyroid functions are very important to optimize. Aggressively treat nausea to avoid vomiting. The flap donor sites, in terms of this sort of summarize everything, so latissimus flap, just avoid axillary compression. For the fibula and LT, you can start walking on it. Just for the fibula, we just don't walk too much because the skin graft can shear, but they can ambulate with assistance. And for the arm, for these radioform scapula and pec flap, you can use your arm, however they want. It's really pain tolerant. All right, any questions?
So, our post-op, are these some are these patients sometimes on muscle relaxants? Because I would imagine that this is painful.